Hi, I'm Julie Levinsky, Web Manager for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to this very special presentation of Ask Nurse Linda webcast. It's about bladder management. It's hosted by our partners Hollister, and also Nurse Linda has some friends with her today, and I'd like to introduce you to our friends from Kessler Institute for Rehabilitation. We have Nurse Manager Robin Bischoff. We have Clinical Coordinator Meredith Cole and Senior Case Manager Jane Mitchell, all from Kessler Institute for Rehabilitation. And I'd like to just also tell you a little bit about Linda, who is your host for most of these webcasts. She has been a leader and a provider of rehabilitation nursing for over 30 years, and a friend of the Christopher and Dana Reeve Foundation for close to 20. As soon as Christopher Reeve was paralyzed, she worked closely with him on his recovery. And she also moderates our Ask a Nurse discussion, which is on our online paralysis community. So I would like to now turn it over to Linda to get us started. And if you have any questions, please put it in the chat box, and you will also be able to ask questions over the phone by pressing *1 on your keypad. Hi, Linda.
Hello, good morning, and good afternoon, and hello to all of our guests who are on the webinar. And first of all, I'd like to say a grateful thank you to the Hollister Corporation, as well as to our guests, Robin, Meredith, and Jane, who are rehabilitation nurses, specialty near and dear to my heart. So my fellow colleagues who are here from the Kessler Institute talking about urinary problems this session. So since we have some special guests, I thought we'd start off the day with just kind of like an interview with them, and we'll incorporate your questions as we go along. So there's all types of bladder management that can be used. Techniques can be used to help control bladder and manage bladder function and maintain continence. So today we're going to focus mostly on intermittent catheterization. So if maybe Robin, Meredith, or Jane, could you talk a little bit about who can use intermittent catheter, why it's a positive treatment, and how it works for bladder management?
So I can talk about what we do at Kessler. We encourage intermittent catheterization for most of our patients. There are few exceptions, but most of our patients, whether they can catheterize themselves or not, we do encourage intermittent catheterization. The exceptions being if a person is elderly and we wouldn't want to catheter, example, a 90-year-old woman every 4 hours. Other than that, we catheterize all of our patients, knowing that there's a possibility that they won't be able to catheterize themselves when they go home. Then we look at alternatives. But we still try to put most of our patients on intermittent catheterizations.
We also, this is Jane, we also have for our patients, which is a very, I think, unique approach, we have a trial backpack program. And what that is that in conjunction with the nurse, the trial backpack is given to the patient. The contents of the backpack with the different types of catheters, straight catheters, hydrophilic catheters, are all reviewed with the patient so that they can see the different types that may work for them. We like doing this approach and started this about 13 years ago actually, because we found that there are so many catheters out there on the market that are just great, and they may not be what's on our formulary, but we wanted to give the opportunity for choice to our patients so that they could trial various types of catheters and select the one that best works for them. So that's been very successful, and we then order that catheter for the patient to go home in. And again, it may not be the catheter on our formulary, but it's the catheter that works best for them, because we really do like an individualized approach to intermittent catheterization for all of our patients.
And as a response to that, we have a couple of questions from some of our listeners. And one is a question about the catheters being too long for females, the standard catheter being too long for females to catheterize on the toilet. So in your individualization of catheters for different people, could you talk a little bit about the specialty catheters available for females versus male catheters?
They do have separate catheters for male and female patients. They are smaller in length for the female patients. It's just a matter of asking the provider or your supplier to send the female catheters instead of male catheters.
And to follow up on that, Meredith, thank you. To follow up on that point, we do then, for all the manufacturers that we work with, and they are really great, they're good supporters of the program, we do ask them to please remember to send along both female length and male length catheters, because it would make it so much easier for them to be independent. So we do have both male and female catheters for the 5 companies that manufacturers that we deal with.
Okay, so there are options for males and females. We have another question that someone has asked is, why is a catheter with a protective tip better than a catheter without one?
The protective tip is supposed to be helpful in bypassing the bacteria in the beginning of the meatus, but there are straight catheters that people use that don't have the protective tip. It's just a matter of being clean when you do your IC and to manage your bladder volume. But that protective tip is just there because of the sterile closed system. It's to bypass that bacteria in the beginning of the meatus.
And I see we have a hand raised. So, Julie, I'm going to ask you how we talk with this person with their hand raised.
Sure. Michelle, if you're on the phone, please dial *1 to ask an audio question. And if not, please use the chat box to type in your question, and all of the presenters will be able to see it. Ronnie, this is probably a good time to ask if we have any audio questions.
Again, if you'd like to ask a question, press *1.
Okay, thank you. So we'll wait for Michelle, and then we'll just, if Michelle dials in, Ronnie, go ahead and interrupt us.
Okay, we'll wait to hear from Michelle. We're hoping to connect with you, Michelle, so please dial in because we're anxious to talk with you. But in the meantime, we'll go ahead with our answering some of the questions that we have and some of our presentation for today. So if you rehabilitation nurses wouldn't mind discussing some of the processes, what's the basic process for intermittent catheterization. And we do have a question in relation to this about a pediatric patient who's on an every 3-hour intermittent cathing schedule but with no medications, and sometimes she has some breakthrough incontinencies of urine. So there's asking about some medication that might help her stay dry throughout the day, and just what the general process would be for a pediatric patient catheterizing every 3 hours. What are your thoughts on that?
Well, in regards to medication, I mean, that would really need to be from the physician or the urologist that they're working with on whether or not they need the medication. There could be different reasons why somebody is leaking in between their ICs, so it's kind of hard to answer that question without having more testing and more knowledge about the patient.
Okay, so maybe we can get some more information from our listener on that particular subject. What do you do in general for adult people for intermittent catheterization? What's the, for our listeners, they've all been to a variety of institutions. They've all had training from a variety of people. Can you just kind of review what the most typical schedule for an adult person would be for intermittent catheterization, how they control their fluids and manage their intermittent catheterization schedule itself?
Okay, well, typically we have our patients, if they're drinking about 2 liters of fluid a day, it would require you to catheterize about every 4 hours. And then what we do try to tell them is to limit their intake of fluids after dinner, only taking fluids with medication in small amounts so that they're able to go through the night and not have to wake up to do any intermittent cath, trying to IC right before you fall asleep and then as soon as you wake up in the morning. But you do have to watch your bladder volumes to make sure that you're not overfilling the bladder. We like to keep the volume under 400 if possible. So you may, in the beginning, need to wake up once just to check to make sure that your volumes aren't going to be high. But we try to tell the patients that, when they get into bed, there really isn't a schedule. Once they get in, if they're in bed for about an hour, they should go ahead and try to catheterize themselves, just because if they've been up in a wheelchair or something during the day, their legs are dependent, and we want to see if that fluid has then been made into urine. So once they get into bed, they should wait about an hour and catheterize again. And then, depending upon how long they're awake, once again right before they go to sleep, so that they can try to go through the night without having to do the IC.
Okay, and then we have a reader that has a follow-up question about that. This is in Spanish, so I hope I'm translating correctly because Spanish is not a high skill of mine, but it sounds like the reader is looking for information about how to avoid infection when doing intermittent catheterization. So could you talk a little bit about infection and maybe clean versus sterile? So many of our patients, when they're in the hospital, they're using sterile technique. When they come home, that all of a sudden they've been switched and now they're using clean technique, and it's confusing for a lot of people why it should be sterile in one environment and clean in another. So could you just talk about the difference between sterile and clean technique, and then what you can do to help to avoid an infection?
Sure. Well, in the hospital setting, we try to keep things sterile because you are in a hospital setting. But once you go home, you can do clean technique. It's just a matter of, again, keeping your bladder volume under 400 because you don't want to stretch the bladder. If you overstretch the bladder and get too much in there, that allows the bacteria to get into your system and give you the infection. So if you keep your bladder volumes under 400 and just make sure that you're washing your hands and washing the genitals before you do the intermittent cath, and keeping your catheter on a clean area, not allowing it to touch anything where it can be getting contaminated other than your clean hands, you should hopefully be free of infection. It's really a matter of not overfilling the bladder and just keeping your hands clean.
So there are a lot of foreign germs when you go into the hospital. There's a lot of bacteria, and that's just in the environment that's not the same bacteria that you become accustomed to at home. Wouldn't you say that's part of the problem also, that in the hospital, there's a lot of information about the dangers of actually being in the hospital, and
Correct.
You have so much more exposure to so many things. There is also a question, another follow-up to this. It's related, but it's kind of an offshoot of this. But we have a reader that's written in a question about changing from a leg bag to a urine collection, a night collection bag, and what tips can be used for making that transition to avoid infection.
Well, when you do disconnect from the leg bag, depending upon if it's a brand new night bag, bed bag that you're using, it will be sterile. But if it's not, you can take an alcohol, a bottle of alcohol and a cotton ball and just clean the opening before you put the Foley onto the bed bag.
So that will help keep it clean also. And then as another follow-up question, that it's always interesting what people write in because it's all related, but it's so many thoughts that sometimes it doesn't seem like it flows together, but it actually really does. So we have another reader who's written in, and they have a question about intermittent catheterization, but they have a suprapubic catheter, and they're having some leakage from their penis, even though they have the suprapubic catheter in place and intact. So I think they're wondering about intermittent catheterization with a suprapubic, but I think the bigger question is, how do you keep leaking from occurring with a suprapubic catheter?
Well, that is a little bit difficult to answer because typically here, before we insert any suprapubic catheters, our patients do go for bladder testing to find out if their urinary sphincter is weak, because if you have a weak sphincter muscle and then you're going to go and put the suprapubic in, you will leak from your penis, or, if it's a female, you will have some leakage because it is a positional type of drainage there. If you're sitting up in a chair and your suprapubic is in, you may still leak a little bit because of that urinary sphincter. If you cough, it may, there may be a little bit of leakage. So that problem, you would probably have to go and see a urologist. There may be some solutions, whether it is medication, oral medication, or, some other type of procedures that need to be done to try to tighten up the sphincter muscle.
So there is help. So if you're having some leakage, there is help. So having that urinary testing either done by a urologist or a physiatrist who does what's called urodynamic testing is very important. And how often do you think that urodynamic testing should be conducted?
Well, definitely yearly. But then if you're still, if you're having problems like the leakage, if it's a new problem and it's not a bladder infection, then you should have, then you should see the urologist or the physiatrist, whoever is going to be doing the testing, and see if, you need another one. Sometimes they can be done, depending upon what the problem is, sometimes 3 months or in 6 months if there's a new medication started and they want to make sure that the medication is working properly, or if you need more medication. But definitely yearly, and then if there's any problems, as needed.
So that's a good tip for all of our listeners, is to really pay attention. If you haven't had urodynamic testing, it would be time to start that. It's a good test that really indicates what's going on in your bladder, and it's good to get a baseline, even if you're having no problems. If you've never had urodynamic testing, hopefully you have. But if you haven't, it's a good test to have to get a baseline so you know where you are. So if you do develop any kind of new symptom, a problem, something that's changed in the way your body's functioning, if all of a sudden you're having leaking where you didn't have leaking before. And as we age and as we go through life, our bodies change, different things happen to us, so it's always good to report when you're having any kind of significant change in your bladder function. So I'd like to ask our rehab nurses, what should you do if you're you're managing your bladder and something doesn't go as planned. So what if you're doing intermittent catheterization and you stay dry, but all of a sudden you do become incontinent, or you do have some leaking, or we have a question from a listener also that is asking about what if there's so much sediment in the urine that it clumps up in the catheter and it's difficult to get the urine out. So what can you suggest for these readers that are having some kind of problem with their catheterization program?
That is an interesting question.
It's a loaded question for sure.
I'm not quite sure. You should always carry extra catheters so that if the one does get blocked, you can try to use another one. But with the leakage, if either having a change of clothes or making sure that you have some kind of like protective pad before you go out, just in case that there is some leakage. If you have the excess mucus or leakage, it could be a bladder infection. So definitely, if that happens when you do go out and it's not something that routinely happens, then I would definitely follow up with your physician to get a urine specimen to just make sure that you're not having some kind of infection.
And so what would the symptoms for infections be for our listeners? Could you just review those for them?
Sure. Well, there's a difference between, if you're not symptomatic and your urine looks a little cloudy, you may just want to increase your fluids a little bit and do some extra catheterization. But sometimes leakage or increased spasm or, the cloudy urine in combination with those two can be concern for infection.
And so sometimes you won't feel if there's pain. A lot of times people have pain or discomfort. You might not feel that, but your body might react in other ways too. So if you're having pain from urinary tract infection, it could be referred to another area, or you might get, like a queasy feeling in your stomach. So sometimes it doesn't come out as, some of the more traditional types of urinary tract infection pain that you might or symptoms that you might read about on the computer, because sometimes, as we all know, with any type of paralysis, those messages might not be getting through clearly. So it's really something you need to be on top of and know your body and how your body is feeling about things. So we have another listener who's written in, and they have 30 years of chronic UTIs, and their question is, what can be done to improve their bladder health and prevent them from getting sick? And yes, they know it's a big question, and they acknowledge that. So our readers are very sophisticated. But
emptying their bladder.
Yeah. What can they do to improve their bladder health?
But the person that's getting a lot of infections, it depending upon how they empty their bladder, if it's intermittent cath, they could be overfilling or not keeping everything clean. Or I'm just reading the question real quick.
There's medications they can use to prevent.
This person is on intermittent catheterization and already on medication for their bladder, or I'm just trying to figure out which question that is and how they're emptying their bladder.
There's a lot of
catheter. There could be bladder stones involved, which are bacteria, so you won't get rid of the infection until you get rid of the bladder stone. But if it's intermittent catheterization, it could just be their their volume of how much they're holding in their bladder, or not keeping everything clean when they're doing their catheterization. So it's kind of hard to answer that question about infection if I'm not quite sure how they're managing their bladder.
So we need a little more information from our listener on that one. We have another person that's writing in about her daughter who refuses to cath, and she wants to know what she can do to help her 16-year-old daughter. So she has a teenager, and we know that teenagers oftentimes don't like to comply with rules and regulations just in general. So what do you do for a person? How do you help a person who apparently needs to be on a catheterization program but just refuses to do that? What kind of strategies would you be using?
Well, for us, if they're non-compliant with their catheterization program, we would then suggest going to the indwelling catheter, whether it be, the suprapubic or a Foley catheter, because not cathing is just as bad as, you're going to set yourself up for bladder infection, and, you need to drink your fluids, so not drinking your fluids because you don't want to cath yourself is not healthy either. So we would then have to try to persuade them to go a different route for their bladder management, because you have to catheterize yourself. You can't skip the catheterization.
Yeah, and the complications are pretty serious. There are only 3 openings in the bladder, and one is the urethra where you're going to catheterize, and the other 2 openings are to back up into the kidneys, and the body is built so that that doesn't happen. But if you're not catheterizing and the pressure builds up so greatly, there is a possibility, well, you're either going to be incontinent or that urine is going to back up into the kidneys, which the kidneys do not store urine. They only process it. So there's a lot of complications from that. So that's something very serious. You should really talk to your healthcare professional, and sometimes involving that rehabilitation nurse with teenagers and taking the parent kind of out of the loop, but really involving with a nurse. Sometimes teenagers are a little more amenable to listening to other people. That's not necessarily going to be the answer, but it's certainly one strategy that sometimes works with people that are having a hard time, and then looking at the bigger picture too of adjustment to disability. So there's a lot in that question also. I'm looking at another question, and it's about a person who's doing intermittent catheterization, but they're thinking about changing to a suprapubic catheter, and so they wanted to know more about the pros and cons of that, and also what I think a lot of our listeners aren't really familiar with is the mitral fan-off procedure. So could you ladies talk a bit about what would make somebody make a decision? What would be some factors that would indicate that maybe they should change to a different type of catheterization process, and what those different kinds of treatments might be?
So the question is about going from intermittent catheterization to a suprapubic catheter?
Mm-hmm. Mm-hmm.
Okay, so you're going to have the same types of pros and cons that you would have had with a indwelling Foley catheter. The one advantage of having a suprapubic catheter is that it can be a little bit larger in diameter to help empty any of the sediment out of the bladder, so that hopefully will help with the decreasing infection, although it is still a foreign body, so there are still that chance of having an infection. But it allows you to not worry about your intake of fluids. You don't have to be as controlling of your fluid intake. You can drink a little bit more than you would on intermittent catheterization. But you do have to wear a, some sort of collecting device, the leg bag and the bed bag, and have them, switched back and forth between the two. So, you do have to manage the emptying of the urine that way when the bag gets filled, and then, having it secured on your leg, and, depending upon what kind of clothing, managing the clothing to be able to empty that leg bag. We don't really see too much of the I'm sorry, I have a blank now.
The mitral fan-off?
Right, we don't see very many of them here because we don't have a lot of pediatric patients that come here with them.
Okay, yeah.
I can't really
Yeah, so some facilities offer it and some don't, and it's really kind of up to the consumer if they choose to go that route. But it's a surgical procedure where a little incision is made, usually around the belly button, and the appendix
It's more
is
convenient if you don't want to have a catheter in you connected to the bag. And it's a little bit, especially for females, it's a lot easier to manage because you don't have to worry about clothing. It's simply just catheterizing the stoma. But, again, it is a surgical procedure.
And so it's another option, but just something, you always want to know about your options, but you have to weigh them carefully for the risk and benefits for your own personal self. So it's another option to think about also. It makes me think of the teenager that doesn't want to cath, and for females it can be very difficult to cath from the wheelchair and to manage stylish clothes that especially people in the high school environment want to wear certain kinds of fashions. And so sometimes it can become very difficult to catheterize. And speaking of having problems catheterizing, we have another question where a listener has written in and they have a C4 level injury and they would like to catheterize them. They're unable to catheterize themselves, but they would like to try intermittent catheterization with an assistant or an attendant doing the catheterization. But what they're concerned about is the nighttime catheterizing, and how does that typically accomplish for people who have an attendant? In other words, do they have to get someone to catheterize them at night? Can they go a certain number of hours without catheterizing? Can you explain that process to this reader?
Well, when having somebody else catheterize you, it does need then to be a sterile procedure. So whether you're using a sterile closed system, they would have to wear the sterile gloves, or even if you just have a regular straight catheter, they would still have to wear sterile gloves. So depending again upon your fluid intake, you may need to have the attendant wake up to catheterize you in the middle of the night. Again, we try to tell our patients to cut their fluid intake in the evening and to try to do that last catheter as close to when they're falling asleep as possible, so that they can get at least 6 to 7 hours of sleep before they have to do another catheterization in the morning. But if you have a catheter in right now, I would suggest looking at what kind of volumes you're getting and try to curb your fluid intake before you go to switch over to the intermittent cath, just to kind of get an idea. Maybe empty that bag before you fall asleep at night and see how much is in there in the morning, so that you see what kind of volume you're getting. Because you may have to wake up in the middle of the night to do that, to do 1 or 2 ICs in the middle of the night, depending upon how much volume of fluid you're getting.
And that is a great tip and a good idea for a pre-trial to kind of help you get more information about your own body to see what that process would be. And I think also what you had said earlier about once you get laying down and you're in the bed, and then you have that fluid that's collected from your dependent extremities, including your arms and your legs if you have a high-level injury, catheterizing an hour after you are laying down in bed so that your body is basically flat, which allows that fluid to come back up and be processed into urine. So that's using both of those tips are really great ideas if you want to get more information about how your body is going to respond to that. There is a question here about E. coli, and this person says that their urologist said that their bladder is colonized by E. coli, and it seems to be affecting their heart, causing high blood pressure and AFib. Do you have any comments about urinary tract infections and bacteria in the heart?
No.
No.
I can't answer that one.
No.
Now that's a
more
pretty
for the physicians.
Yeah.
Yeah, that's a pretty tricky one. What we do know, though, is that there with mouth hygiene, oral hygiene, there's a high risk with bacteria in the mouth affecting the heart. And so I don't know of any information about the bladder colonization of bacteria in the bladder working in the same way as it does with mouth bacteria. I've never heard of a study that relates those together. And it seems like maybe you guys haven't heard of that either. So that is a very interesting question. We'll be interested in hearing how that plays out because that's linking a lot of different systems together that seem to have not that direct connection, but it's all in the body. So, you know, anything can affect anything in the body. That's an interesting question. Let's see, what else do we have here? Here's somebody who has had the mitral fan off. Their daughter's had the mitral fan off and is still having 2 to 3 infections a year. Do you have any comments about that? Infections with
not
catheterization, really?
It's everybody's body is different. You know, sometimes way back, long time ago when I first started, they used a lot of vitamin C and Hiprex, but that would be, you know, something that you'd have to talk with your physician about medication-wise to try to get some stuff that, you know, help to prevent infection.
And if she's just using a straight catheter, can she use a closed system?
That may help.
Since she's had infections, it would be covered.
Right. Yeah, that's another area that we haven't really discussed is what is the insurance coverage for the straight catheter versus the closed system. So the Medicare patients struggle with this because closed systems are not covered by Medicare unless you've had 2 documented UTIs in a year. So oftentimes our patients do have that, and that certainly helps them. But that's a challenge, you know, for many patients that we have ongoing here at Kessler.
So we have another question about a suprapubic catheter, in that this person has been told to drink water, drink water, drink water. And so they want to know, how much water should they be drinking, and how do you know when you have enough water?
I'm sorry, we missed that. We had a little emergency that came into my office here. So sorry. Can you just?
Oh, that's okay. Somebody has written in and they said they're told they have a suprapubic, but they were told to drink water, drink water, drink water, and they want to know how much water is enough water. And I think that question, even though they have a suprapubic, how does it relate to intermittent catheterization also? Just how much water should you be taking in, and can you drink other things like coffee or soda?
So the best thing is water or clear liquids. And as far as I know, with a suprapubic, you can drink all you want. It has nothing to do with intermittent catheterization because it is constantly draining.
Okay, but on it, so with intermittent, how do you manage your fluids?
So with intermittent, we limit them to 2 liters a day. And then we watch their outputs. We try to keep it under 400, and we adjust the times by it. If they're over 400, 500, 600, we'll maybe make them go every 3 to 4 hours. If they're cathing and they're only getting 200 to 300, we let them go to 6 hours.
Okay, so that's a good tip to know if you're doing the intermittent, how you should go through and the 2 liters. So if you think of 2 liters of water, that's the size of a Coke one of those giant Coke bottles. So that gives you an idea of how much 2 liters is. Let's see. Oh, so then this person does have a question about other fluids such as coffee. So coffee contains caffeine, so how does that affect your bladder program?
So caffeine is a diuretic, so we would limit caffeine.
And caffeine comes in coffee, tea, sodas, chocolate. So if you're eating a lot of chocolate that has caffeine in it, will that affect your bladder program?
I mean, caffeine, of course, is a diuretic, type product. So, I mean, if there is somebody that really is insistent on certain foods, we do have the nutritionists meet with our patients so to explain to them about their bladder health and foods that are good for bladder health and foods that may aggravate issues with respect to intermittent catheterization.
So people need to realize that you might be drinking caffeine, but also you can eat caffeine through a variety of foods. So caffeine is going to enter your system. It's going to affect your urinary tract function no matter how you get it in your body. So it's an important thing to know. Now, for people who are going home, when they're in the rehab setting, that's everything is kind of set up. The catheters just appear. They're in nice little kits. The bathroom is set up. It's usually large that people can transfer in and try to use the bathroom to catheterize, and they learn all different skills. But do you have any tips for the person who then goes home and how they transition to the home environment? When the bathroom's not set up, catheters come in one package and the lubricant comes in another package, and you have all these separate pieces of equipment, and your bathroom is not set up with a handy little tray to put it all out on. And any thoughts about transitioning to the home environment?
Try to transition them before they go home with what they're going to use at home. We typically don't catheterize in bathrooms here. What we use in-house is a closed system, so it's a very easy system. But if a person is going to get a straight catheter where they get the lubricant separate and they need to drain into a urinal, we give them that prior to discharge so they can practice it here, so they know what they're doing when they go home.
Okay. And so when they go home, somehow, I don't know how it is, but somehow, marketers get people's names of people who are using catheters. And all of a sudden, people will be inundated with these advertisements for every single kind of catheter on the market, and switch to this catheter and try this catheter, and you need a closed system. No, you need a straight system. No, you need a female catheter. No, you need this other thing. And so it's really kind of confusing for people. I know you have the backpack idea, which is a great idea, where they get to try a bunch of different pieces of equipment, but not everybody goes to a high-level specialty rehabilitation center. So there's a lot of people that are just inundated with all this information about different kinds of catheters. So could you talk just a little bit about the different types and what maybe the advantages and disadvantages of those different catheters might be?
So here at Kessler, we're big advocates and fans of the hydrophilic catheter, so you don't have to worry so much about the lubricant and setting all that up, because when you're home, that's a challenge. Some individuals, their space may be confined, that they would not be able to set up a clean field with which to, perform intermittent catheterization. So the companies that are manufacturing these catheters are moving, along the lines of lubricated catheters like hydrophilic catheters. So that eliminates that step. So we encourage patients to maybe look towards the hydrophilic catheters because they are pre-lubed. It's a simple step, whether it's a closed system or a straight system, because it is very challenging if you're in a very confined area in your home and trying to be able to do that function. The bathroom may, of course, be very narrow. Maybe it's not an accessible bathroom because of narrow doorways, etc. So here we try to encourage patients, and overall the hydrophilic catheters are really, they've come so far, and there's so many different types, some that are stiff, some that are a little bit more softer, more limp. So there are so many good ones on the market now that individuals can just go online, and see. And going back to that discussion point that we had a few minutes ago about coverage, insurance coverage, Medicare for some of our patients is probably the most challenging for coverage for these closed systems, these hydrophilic closed systems. So they're pre-lubricated catheters which has a closed system attached to them. Medicare does not cover those systems, but yet they will cover a straight catheter that is a high-end catheter that's hydrophilic, very simple. The packaging is evolved over time with loops and different aspects of it that a patient can kind of tear off with, biting it and tearing it. We've seen many of our patients who are high injury tetraplegic patients able to catheterize themselves because the packaging has evolved so well over time to meet those needs of those patients with limited dexterity. So I think the consumer going online can really see some of these catheters and how they're very user-friendly, but the only separation from coverage to not is really the Medicare patients, which only have coverage for straight catheters versus closed system catheters.
And so for the patients who have problems with getting these more advanced catheters, there are some regulations usually within the payer where if you have so many documented urinary tract infections, you can move to a more sophisticated closed system catheter. But that you have to check with your provider to see what the regulations are for that. Or if you really think you would like to try a different catheter, you feel like it would be good for you, you can talk to your payer and ask for a nursing case manager who can perhaps work with your insurance, and they're usually hired by the insurance company themselves, and you can negotiate with them to see if you can get one of these catheters on a trial, or to see how that works out for you. So if your insurance does not pay for it automatically, there are systems that you can go through to try to get some of these different products covered to see if they will be more supportive in your care. Also, I wanted to mention too, on the catheters, we talked about all different kinds. For males with who are having prostate troubles, there's also a catheter that has what they call a coude tip. It's COUDE with a little accent over the E. So a little coude tip, which is a curved tip, which makes it easier to pass a catheter around an enlarged prostate. So when we talk about the hydrophilic catheters and the female catheters, there's also a specialty if you're a male and you have trouble passing your catheter. So there's just about something for everyone, wouldn't you say, ladies? There's almost, there's such a variety that it seems like there's just something almost geared for every single person out there.
And every day they're making advances and coming out with new catheters. Not only do the consumers get inundated, but we do too.
And you are great resources. So think about your rehabilitation nurse, because they are great resources. They're being inundated with catheters. I have a big package over on my desk right now of a new product that just came out, and so we get a lot of these, and we have patients try them, and we try them on patients and see how they work, how easily they are to handle, and that sort of thing. So be sure and talk to your healthcare provider and your nurse, because they probably are going to know some different options for catheters that maybe you have not been aware of. Or, sometimes we get advertisements, and much like TV, we get so many advertisements for drugs, and, oh, this is the best one, and everybody should be on this drug, and, maybe that's not appropriate for you, so you might be getting advertisements for different catheters that maybe that's not the best fit for you, but maybe there's another product out there that is. So consider all of those kinds of things too. What other kind of message would you like to leave with our listeners, my fellow rehab nurses? What do you think is the takeaway message that our listeners really need to grab from today?
Before we give a takeaway message, I would like to say one thing. When we were talking about noncompliance and ideas to get teenagers and other people that don't want to cath, education by a peer is the big thing now, and I know most of the bigger rehab hospitals, that's what we use. So if you have a 16-year-old female that does not want to cath, the best way to teach her to cath and encourage her to cath is another 16-year-old female.
And that is a wonderful tip. And may I say, if you're out in the community, we have the peer-to-peer program at the Christopher and Dana Reeve Foundation. So if you contact the foundation and if you have a teen at home, or if you have a family member who's struggling, or if you are struggling and finding the equipment that you need or resources in your community, be sure and contact the Christopher and Dana Reeve Foundation, because they have a peer program, and they will find somebody who lives in your community that's familiar with the resources right there in your hometown, in your community, or at least nearby, and they can connect you with people who've been out in the world for a while and have kind of navigated the world with some success. And so it's when you talk to somebody like someone your own age, if they're a teenage person, or if you're an adult person, or if you're the parent of someone or the wife of someone who has a spinal cord injury, it's a great idea to contact them, and that gives you some extra resource from somebody who's been through situations that you're going through also. So any other thoughts that you might have for our listeners?
Not to be afraid to ask questions. Reach out to us. There's nothing we haven't heard.
Absolutely. You will not be shocked, I can guarantee you. So yes.
We do have some questions on the phone line. Okay, and the first question is from Richard Eldridge.
Hello.
Yes. Good afternoon. Thank you for putting on the seminar.
Well, thank you for listening. And did you have a question?
You read a question earlier. I wasn't sure if it was related to the one I submitted, but there was the question with a chronic indwelling Foley user versus a suprapubic Foley user, and the pros and cons of each. I heard about the ICP versus suprapubic, but I was wondering if my question was fully understood the way I typed it.
So you want information about intermittent versus indwelling?
No, that's the one that you read, but I submitted one as a chronic indwelling Foley user versus a suprapubic option. I've been doing the indwelling for 17 years, and there's been recommendations to switch because that's what everybody does, quote unquote, I've been told. I did my inpatient at Seattle Harborview in '97, and at the time they were like number 3 in the country, I was told. And I'm wondering if I'm using the best method out there as a C5 patient. I had a C4, 5, and 6 break from a car accident.
Okay, ladies, do you have any suggestions for this man?
So I would suggest suprapubic, like they're telling you. If you can't catheterize yourself, you have a Foley catheter, it's just so much easier for your caretakers to change a suprapubic.
Okay, I understand that, sure.
You might want to, meet with your urologist again. Maybe you need updated testing, urodynamics, and maybe have that discussion with your physician with respect to that. Many of our high injury patients do opt for a suprapubic catheter for a variety of reasons, ease of caregivers, as Robin just mentioned, for sexuality reasons, and they're very simple to change. Decreased sediment issues that Meredith was talking about before because of the larger French size, so you don't have that clogging and some of those other issues that develop with chronic Foley catheter usage. So maybe perhaps meet with your urologist and have a new look at a new way of managing your bladder needs and investigate that.
Because I'm an indwelling Foley user, I have an electric leg bag system. I was institutionalized for 3 years, but I've been independent and living on my own for the last 14. I've had to pay for a majority of my home attendant care, and my nursing staff is, as far as the hours of coverage, is less than desirable. But because I have no feeling and sensation, and my leg bag is under my pant leg, I don't have any sensation to know when that bag is full near my leg. And over these amount of years, several times a week, I've been distended, and I've learned something new. I didn't think I would, but I've come to understand that distension of the bladder can put bacteria into other parts of the body that would increase your rates of infection. But because I've been going this long, doing it the way I have been doing it, not knowing that, I've generated a problem with frequent right flank pain, and I've been told by some doctors it may be bladder spasms or kidney spasms, and I'm wondering what your take is on that related to bladder management issues and distension.
We're trying to make sense a little bit of that question, and it's hard. We're not physicians, to be able to respond to that fully. I think we would have to point you in the direction of your urologist to see if there's a connection between, those spasms and what these symptoms are that you're speaking about. I think that's a little hard for us to be able to diagnose, in this forum.
Have you had patients in the past that have experienced kidney or bladder spasms that are chronic Foley users?
Yes, we have. But as I was saying before, the vast majority of our patients tend to opt for either a suprapubic tube. They opt for intermittent catheterization if they have a caregiver that's willing to do that.
Are you getting dysreflexic from the bladder spasms? Because we have that happen a lot, and then they use Botox to help into the bladder. Do you have any dysreflexia?
I believe that I have to have beginning phases when my leg bag has become over capacity.
Right.
Yes, so I've had some beginning symptoms of AD, but I haven't ever had full-blown AD from that issue, except on very rare occasion.
The last time you did have bladder testing?
It's been a long while. I would say probably in only the first year or two after my discharge from the hospital as an inpatient.
So you definitely need to do that.
Yeah.
And they'll make recommendations for you.
Yeah.
All right. Well, thank you for answering my question.
You're very welcome, sir.
So hi, this is Julie Lubinsky, and I just wanted to, we're a little past 4, so we need to, unfortunately, end the webcast now, but I want to thank everybody for joining us, and there's so much response. We're going to hopefully we can have a part 2 to this, because there's still a lot of questions out there. A lot came in, so I appreciate everybody's questions. And I wanted to let everybody know they can find out more about bladder management on our website, christopherreeve.org/bladder. We also have that we worked with Hollister on a bladder management booklet. It's a PDF that users can download as well, and that's also found at christopherreeve.org/bladder. Linda, do you have any closing
Yes,
thoughts?
I would very much like to thank all our listeners, and I'd like to really thank Robin, Meredith, and Jane for your valuable information and all the help that you've provided to our listeners today, and also to the Hollister company for their support.
Thank you, Linda.
Yes, thank you. All right, thank you, everybody. Thanks for joining us today, and look for the information on the next webcast with Nurse Linda at the end of next month. And this is also being recorded, and by the end of the week, you'll be able to view it on our YouTube channel. Until then, thank you, and have a good rest of your day.
All right.
Thank you.
Bye.
Bye.
Ladies and gentlemen, that does conclude the webinar for today. We thank you for your participation and ask that you please disconnect your line.